Mr. Sykes, can we do roll call?
This is Chris Sykes, certainly. Pardon, get in my seat. I apologize.
I'm not sure people can come on mic to answer that they're here.
Kelly is gonna open up the individual allowed to talk and let people announce themselves. But we do have 6 members sitting right now with us. So, well, Mr. President, would you like to continue through roll call or would you?
Yes, let's move.
Okay. J.K. Costello,
Excused.
Morgan Honey,
Excused.
Amanda Jaslinski,
Present.
William Kennard,
Here.
Barry Martin,
Here.
Cassandra Littler.
Here.
James McLaughlin,
Here. Sorry for being late, everyone.
Christina Mulkey. You're in there, Christina, we saw you. And David Pump.
Excused.
Mr. Vice President, we have a quorum.
All right, so announcements are the date and location of the next Medical Services Board meeting is scheduled to be held Friday, August 14th, 2026, beginning at 9 a.m. virtually and in person here at 303 East 17th Avenue, 11th floor, conference room, Denver, Colorado, 80203. If you're listening via audio stream and lose the connection, please click again on the link to rejoin the meeting. Closed captioning is available on your Zoom toolbar and staff will chat out instructions. Please identify yourself when speaking comments as they are part of the public record. It is the responsibility of the Medical Services Board to adopt the rules that govern the department's programs through consideration of stakeholder input in alignment with the department's mission and in the best interest of Coloradans. There is testimony sign up for each rule. If you need help finding the rule in which you are interested, please ask staff for help. Please keep your testimony related to the rule being discussed. Thanks so much. And now department update, I think, is Adele.
Yes. I'm sorry, I'm sitting in front of Rachel's computer right now, so it may show me as Rachel. Hi, everyone. Adela Flores-Brennan, Medicaid Director from the department, who cannot access the internet on my laptop at the moment. But I wanted to just start out with recognizing and naming the difference in the composition of the board as of this morning. And I'm also recognizing that it's going to be a surprise to many, if not all of you. But just as of yesterday, the governor has made some decisions on appointments to the board. We had a couple of people whose terms ended on June 30th. And a vacancy, and so things are shifting. So the governor, as of yesterday, appointed Jared Hughes, who's joined us in the room today, and also former Senator Jim Smallwood. You may remember him as chair of the HHS committee. He was not able to attend today, and then there are some of our members who are still pending reappointment. But we also have a member who is not reappointed, and that is Laura Carroll. And so Barry is serving as chair today in his role as vice chair of the committee. And I want to make sure that we publicly thank Laura for her service to the Medical Services Board and for all of the advocacy that she did on behalf of members as well as people living with disabilities. So just recognizing that holding space for the tension because of all these really recent changes. Thank you, Dr. Martin, for stepping in as chair. I think we will see some additional appointments in the next month or so. And we will schedule elections for the October meeting. So just moving through those announcements, I will give a few updates from the department. You may be aware that Senate Bill 26-187 established a 10-member legislative commission on Medicaid, and they have had a couple of meetings so far. And will be, I think, meeting roughly every 2 weeks throughout the summer. So far, there's been a lot of establishing work, just to establish the rules of the commission, getting a facilitator on board, a lot of questions and requests for data that are coming in. So we will keep this board updated as things move through that commission. Also related to HR 1, or the One Big Beautiful Bill Act, however we want to name it, there are going to be a lot of eligibility changes, of course, that come because of that new federal law. And so you will be seeing some rules come through the Medical Services Board. We have gotten already a lot of feedback on some of the rules that we were planning to bring related to eligibility. And so we anticipate that we will be delaying the rules that come before you so that we can incorporate all that feedback. There's a lot of complexity in those rules. For now, just for your awareness, the first set of changes that are going to come are related to qualified immigrants. We expect this to impact 6,000 to 7,000 refugees, asylees, and other categories of immigrant who currently are eligible for Medicaid and will no longer be eligible and will lose coverage. We have started noticing those individuals, and we are setting up an ambassador program with community-based organizations to help do education and outreach where people are in the community. We also have our toolkit that is launched and a screening tool that can help people navigate whether they are subject to work requirements or work reporting requirements under the new law. I also wanted to announce that our statewide NEMT broker rollout has launched. It is launched currently within the 9 metro area counties as of July 1. I think we've seen a little bit of what we would expect from a new launch as we've completely moved to a different vendor. And so there, were some longer hold times initially, but we're seeing that tracking down as the weeks have gone by. So things seem to be moving okay. We're going to make sure everything is functioning as well as it can in those 9 counties before expanding to the rest of the state. So with that, I will turn it back over to Chris, Dr. Martin.
Yep.
Who gets it? All right, thanks so much.
I have a question with the changes to immigrants being eligible for Medicaid. Does that include emergency Medicaid for pregnant?
So no, pregnant people and children are exempt from those changes because we've adopted other provisions. Emergency Medicaid will continue to be an option for those folks. But of course, we know that that's not a substitute for full coverage. So
Great, I'm sorry, I didn't introduce myself before that question. This is Barry Martin asking the question and Adela answering. Thanks. So now we will go on to our rules. We have our emergency adoption of 2 rules on the table. And is someone going to present on document A?
This is Chris Sykes. I believe we're still having an issue getting Alondra Yanez, who is the rule author, into the panelist position. But Chandra Patel, are you online to at least kick us off?
Can we go to document B first and then come back to A? I think I saw Russ Ziegler on.
Good morning. This is Alondra. Are you guys able to see my ID?
This is Chris Sykes. Alondra, we can hear you.
Okay. Sorry about that. I'm not sure. I was trying to ID myself and it would not allow me to.
That is A-okay. This is Chris Sykes again. Alondra, we are hearing you. So if you want to go ahead with the presentation.
Okay. Sounds good. I'll go ahead and get started. Thank you so much. And I apologize for that. All right. So good morning, Mr. President, members of the board. My name is Alondra Yanez. I am the Senior Dental Program Assistant in the Special Financing Division. Today, I'll be presenting MSB 26-04-26-A, revision to the Colorado Dental Healthcare Program for Low-Income Seniors, Section 8.960. Today, I also have Chandra Vittal, the State Programs Unit Manager, to assist with any questions. Next slide, please. The Colorado Dental Healthcare Program for Low-Income Seniors promotes the health and welfare of low-income aging adults who qualify for the program. In order to qualify for dental health care services, an aging adult must be 60 years of age or older, be at or below 250% of the most recent federal poverty guidelines, not be covered or eligible for Colorado Medicaid, or have private dental insurance. Next slide, please. The Senior Dental Program is general funds dollars only, with no matching federal funds and a normal yearly set approximation of almost $4 million every fiscal year. Due to the current state budget deficit, the Senior Dental Program had a one-time reduction of $500,000 in October 2025 for fiscal year 2025 through 2026, and a $2 million reduction for fiscal year 2026 through 2027. Next slide, please. These reductions have significantly impacted dental treatments, especially the reduction in October 2025, as many of the scheduled treatment plans had to be canceled once the grantees were notified of this reduction. There are aging adults now on waiting lists, including individuals in the middle of active treatment plans. In some cases, patients awaiting restoration, such as fillings or crowns, have been put on waiting lists with hopes they don't face worsening conditions. And the worst case scenario are others who had extractions completed and were waiting for the healing process and now unable to receive dentures due to lack of available funding. Next slide, please. During the Dental Advisory Committee meeting in April 21st, 2026, it was brought up that if the current fee schedule rates were going to match Medicaid, it would potentially help 600 more seniors the next fiscal year at $900 per senior by lowering the rates to match Medicaid's. The Dental Advisory Committee discussed the options, and after receiving no negative feedback from stakeholders and only positive feedback from grantees of the program regarding this change, the Dental Advisory Committee decided unanimously to recommend switching the current fee schedule amounts to match Medicaid's. All of these changes are on Schedule A of the rule document, which is known as the fee schedule. This is why we ask that this rule be brought up to the Medical Service Board as an emergency rule, so the seniors impacted by these reductions may be assisted sooner, along with many more seniors that have been put on waiting lists, as more funds will be available if this rule change can be effective July 10th, 2026. Next slide, please. In addition, within this emergency rule, we have included the recent American Dental Association current dental terminology updates, which consist of 8 procedure descriptions and guideline changes, only which all will be on Schedule A on the rule. The procedure rules are D0180 on page 3, D2391 on page 7, D7285 on page 28, D7286 on page 28, D9222 on page 31, D9223 on page 31, D9239 on page 31, and D9243 on page 32. While these current dental terminology updates are not themselves an emergency, we believe it is beneficial to incorporate them at this time to improve efficiency for both the program and the board. First, the grantees and stakeholders will receive a fee schedule that is effective on July 10th with accurate information throughout. And secondly, to avoid the need to separate future presentation, to adopt the 8 procedure descriptions and guidelines update later. Next slide, please. If this rule is approved by the board today, this will allow approximately 600 more aging adults in Colorado to receive oral health care. The treatment plans that were halted on October 2025 due to the reductions of funds may be finished. And the grantees of the program will have a fee schedule that matches Medicaid's rates and updated language on 8 procedures to ensure an accurate fee schedule. Next slide, please. Thank you for your time this morning. I'm happy to take any questions that you may have on this proposed rule change.
Any questions from the board?
Hi, go ahead.
Dr. Kennard here, but someone was ahead of me.
No, go ahead, Dr. Kennard.
Just a quick sort of context question. This seems like a sensible approach to our ongoing constraints, but I'm just really curious about the history of this. If you know it, Amanda, why this population? Why age 60? Why 5 times the federal poverty benefit? And why greater than the Medicaid rates when it was created? I know you may not have been here in 2015, but this just strikes me as this was sort of a one-off of some kind 11 years ago, or sort of bringing into line with Medicaid now. Do you know a little bit of the why?
Chandra, would you be able to assist with this program since you've been in this program for quite some time?
Absolutely. Thank you, Dr. Kennard, for your question. This is Chandra Patel, State Programs Unit Manager. I actually helped with creating this when it was moved over to the department in 2014 with Senate Bill 14, I believe it's 180. I'll have to look at that. But when this came over, it initially was with the Department of Public Health. And it was ran a little bit differently, but when they moved it over, the rates were already set. And when the Dental Advisory Committee assisted the department with recommending how everything should be started, they decided to go ahead and keep the rates the same, which quite a few of them were way above the current Medicaid rate. So those were brought in 2015 with remaining above Medicaid rates instead of lowering them. On some of the procedures, as Medicaid increased their rates every year, some of them got caught up. So we do have some rates that are equal out to that. As far as the 250% above federal poverty level, that actually was a determination of when it was brought over, how it was done as well, and we kept that the same. And then the age 60, that remained the same when it was brought over from the Department of Public Health as well. So all of those basic program eligibility portions were kept when they were brought over. So I hope that answers everything that you had.
Thank you, Dr. Kennard here. Thank you. It tells me what you were working with then. I just think it's always interesting to see how these things get started. But thank you.
This is Kathy Littler. I just had a question if these rates undergo review by the MPRAC or if these are outside of those rates reviews.
Thank you for your question. This actually is a grant state-funded program only. So those rates are looked at yearly by the Dental Advisory Committee. Since this has nothing to do with federal funds nor Medicaid, it is really outside the realm except for the Dental Advisory Committee.
Great, thank you.
You're welcome.
Oh, sorry, this is Chris Sykes. I believe Amanda Jaslinski online has had her hand raised.
Okay,
And we'll
go ahead,
This-
Amanda.
This is Amanda. I had my hand raised. I think I'm taking back my question. I'm still just learning from listening to all of you. So thank you.
This is Jarrett Hughes. I had a question about the wait list. It seems like these shifting down in the fee schedule gets us the ability to provide care to 600 more folks. What does the overall wait list look like?
For this, right now, I don't have a clue. We are actually getting ready to send out our annual report questions to the grantees, and that actually is going to be one of the questions, is to find out how many are currently on the wait list due to that reduction. So I don't have those figures now, but when we submit our legislative report in November, we actually will have those figures then.
Understood. Thank you.
And this is Chris Sykes. Really quickly for yourself, Jared Hughes, as a new member, this is an emergency rule which only lasts for 120 days. So if the rule is to be made permanent, the department will be back to actually have the final adoption. So hopefully they'll be able to understand and have more information at a later date. But just to let you know that, yeah, right, we're going to hear this rule again if they want it final.
Any other questions or comments from the board?
One last quick question. This is Kathy Littler. If you're decreasing the rates, do you think that has any effect on the number of providers who will participate in providing services?
Thank you for your question. We did have one grantee. They did slow down throughout the last couple of years that dropped out of the program. However, we had 2 new grantees that started with the program this year. So we're down 1, but up 1. So, and I guess I want to go a little bit further with that. We're always going to have, with lowering those rates, we're always going to have the probability of more dropping out. This was with the understanding with the Dental Advisory Committee that if the funding is received back, the $2 million that was taken this fiscal year, that they do have the ability to raise those rates back up if needed to keep grantees within the program.
Thank you.
Any other questions from the board? Mr. Sykes, do we have anyone signed up for public testimony?
This is Chris Sykes. I do not have anybody signed up for public testimony on this rule.
With that, I would ask for a motion, and whoever makes a motion, if you could please read the verbiage above the bolded. Yeah, the bolded areas. Thank you.
Mr. Chair, I can go ahead and do that. This is James McLaughlin. I move that all emergency rules that are adopted include a finding that their immediate adoption is imperatively necessary to comply with the state and federal law or federal regulation or for the preservation of public health, safety, or welfare, and that compliance with CRS 24-4-103 would be contrary to the public interests. With that, I move the emergency adoption of document A, MSB 26-04-26-A revision to the Medical Assistance Colorado Dental Care Program for low-income seniors. Procedure rate decrease on Schedule A for fiscal year 2026-27, incorporating the statement and basis and purposes and specific statutory authority contained in the records.
Thank you. Is anyone willing to second?
This is Amanda. I second.
All in favor?
Aye.
Aye.
All opposed? Any abstained? All right, passes. We'll move on to the document B.
Good morning, this is Russ Sigler. Can everyone hear me?
Again, thanks.
Wonderful. Good morning, Mr. Vice President and board members. My name is Russ Ziegler, and I'm a compliance and policy advisor for the department. I'm here to present the non-emergent medical transportation rideshare authorization rule, MSB number 26-01-29-A. Courtney Sedan, the department's transportation policy specialist, is also presenting with me. Next slide, please. So the reason we're bringing this as an emergency rule, House Bill 26-1328 was just passed in this last legislative session. That bill added Colorado Revised Statute 25.5-1-804, Section 19, which authorizes transportation network companies, which I'll refer to as TNCs moving forward, otherwise referred to as rideshares, to provide non-emergent medical transportation, which I will refer to as NEMT moving forward, services in limited circumstances. The current NEMT rule does not include TNCs, so the purpose of this rulemaking is to authorize TNCs to render NEMT in compliance with the statute. Next slide, please. So what is a TNC or rideshare? It's a corporation, partnership, sole proprietorship, or other entity permitted by the Public Utility Commission, and operating in Colorado that uses a digital network to connect riders to drivers for the purpose of providing transportation. So the most common ones you're probably all familiar with are Uber and Lyft. Next slide, please. TNCs are authorized to provide NEMT services under the following circumstances under this new statute. So the NEMT provider originally assigned to complete a trip is unable to fulfill the assignment, and no other enrolled NEMT provider is available to complete the trip within the time frame necessary to get the member to their appointment. So that's the first circumstance. Or no NEMT provider is available to serve the member in their county or service area at the time the trip is requested. Next slide, please. The requirements for TNCs are as follows. TNCs must meet the Public Utility Commission, which I'll refer to as PUC moving forward, driver, vehicle, safety, permitting, and credentialing requirements to render NEMT services. TNCs are exempt from the requirements of sections 8.014.3.b.6 through 9 if they hold a PUC permit, and TNCs must be approved by the department. Next slide, please. Each use of TNC for NEMT services must be documented by the transportation broker, including the reason for using the TNC, the reason an NEMT provider was unable to complete the trip, and the date and time of the request. The transportation broker must make the documentation available to the department upon request for audit purposes. Next slide, please. I will now transfer this over to Courtney Sedan, our transportation policy specialist, to complete this presentation.
Thanks, Russ, and good morning, Mr. Vice President and board members. My name is Courtney Sedan, and I'm the non-emergent medical transportation policy specialist for the department. The department expects this rule will improve transportation access for Health First Colorado members, particularly those living in rural and frontier communities where provider availability may be limited. We also anticipate improved reliability and fewer missed medical appointments because TNCs can provide additional capacity during cancellations, no-shows, or provider shortages. Existing NEMT providers remain the department's primary transportation network. Rideshares simply provide an additional option when traditional providers are unavailable. Because TNCs are expected to backfill rides that would otherwise require reassignment, the department does not anticipate increased utilization or additional fiscal impact. Next slide, please. During policy development, the department considered input from members, healthcare providers, advocates, and operational partners. Stakeholders generally supported expanding transportation options to improve access to medically necessary services, particularly in rural and frontier communities. The transportation broker also supports adding rideshare companies as a supplemental option to address last-minute cancellations and improve trip completion. Overall, stakeholders supported improving transportation reliability while maintaining traditional NEMT providers as the primary transportation network. This concludes our presentation. Thank you for your time, and I'd be happy to answer any questions.
Thanks so much for the presentation. Are there any questions or comments from the board? Ms. McLaughlin?
Thank you, Mr. Chair. James McLaughlin here. Russ and Courtney, I don't really have any questions. I just want to compliment you guys on this. I think this is, as somebody who provides care in rural communities, this is exactly the kind of out-of-box thinking that improves access to care for everyone. So kudos to you guys. Thank you so much.
Thank you.
Thank you.
Any other comments or questions from the board?
This is Amanda Jastrzynski. I had an additional comment. Just wanted to add that I am also really excited about this. I don't practice in a rural area, but I have patients who have a lot of problems with the existing ride share for numerous reasons. And I'm excited for anything that makes it easier for us to help also our patients coordinate these ride shares, because it's been a lot of work for our care coordinators. And so I appreciate the effort to make this an easier process for the patients as well.
Thank you.
Thank you.
Dr. Kennard, did you have a question?
Yes, thank you, Dr. Martin. I also am going to support this, but with some questions as usual. The first is, who are brokers and how much do they make per ride? That's number one. Number two, how can we say this has no fiscal impact if the whole point of it is to give people rides who otherwise would not get them? And number three, this is Uber and Lyft. Will there be what are the barriers and safeguards to other operators coming in and declaring themselves rideshare companies? And number four, will there be frequent auditing of mileage? This is the boogeyman of NEMT, in my opinion. How will we guard against that Uber ride taking the long way, stopping to do some other things, and what have you? I'm not making this up. This is obviously abuses that we've seen in NEMT in the past. So definitely want to see this happen, but fear it's spiraling in costs.
This is Courtney Seaton. Thank you for your questions, Dr. Kennard. I'm going to try to remember all of them and answer them. The first one you asked, what is a broker and how do they get paid, or how much do they get paid? The previous broker ended on June 30th, and that was TransDev. As of July 1, MediDrive came in and took over the same 9 metro area counties that TransDev was overseeing. The broker is not a transportation provider, so they don't get paid like per trip or anything. I think that might be what you were asking. They do have administrative fees and stuff that they invoice the department, and that's how we pay them. The broker acts as kind of the dispatch or the oversight of our NEMT providers or the drivers that are out there making these trips. And all of the claims currently in those 9 metro area counties and in the future statewide all go through MediDrive. So what MediDrive does before each trip is scheduled is they're verifying that the member has active coverage. They're verifying that the trip is to an enrolled Medicaid facility with an approved Medicaid treatment. So we actually have more oversight now, and we will statewide, than we have in the past. So there is a lot more guardrails in place for that. I think you asked Uber and Lyft. Yes, those are ride shares or TNCs that everybody's familiar with. We will be contracting with Uber Health and Lyft Health. So when all of us call an Uber or a Lyft to go wherever it is we want to go, we're dealing with just like the traditional. These are actually enrolled in their health programs. I believe one of your questions was, what are some issues maybe? Right now, they are all only ambulatory vehicles. These fleets do not have too many, if any at all, wheelchair accessible vehicles. But I've been meeting regularly with Uber, and they are actually looking at bringing in wheelchair accessible vehicles. So that would open up that type of transportation statewide, which we absolutely need. So that is a positive. I think your last question was around the mileage. And again, with the broker in place, everything is done digitally now. Previously, through the other broker, there was paper documents that were being done and really no way to kind of police how that was happening. So now everything is digital. There are, like how we use maybe Google Maps, there are actual NEMT systems that MediDrive is using. And then I believe you also asked about the fiscal impact or how there was none. It's because we're not adding additional trips. So right now we're talking about TNCs, so I'm going to stay on that track. If I go to my appointment at Denver Health and then my ride that I had scheduled through ABC Company doesn't show up, I call MediDrive and I say, oh my gosh, I'm stranded here. Then MediDrive looks, if there's no other NEMT providers available to take that trip right now, they will go ahead and let Lyft or Uber know, hey, Courtney's stranded at Denver Health. Let's go pick her up. And just like when we call an Uber or a Lyft, they usually show up within 10 or 15 minutes or less. And that's how that will happen. So we're not actually increasing the number of rides. We're just helping members that have been left stranded or without a trip. We get them their ride through Uber or Lyft at the last minute. Does that answer all of your questions? And does it make sense?
I think there was one more question about how do we make sure that any old company isn't coming in and saying that they're a TNC. The TNC specifically have to be licensed by the PUC, is my understanding. And so we're only taking or contracting with those who are licensed by the PUC as such.
And this is Rachel, and PUC is the Public
Oh.
Utilities Commission. Just they license things like taxi companies. So just wanted to add that. Thanks.
This is Courtney Seaton. Thank you, Adela and Rachel, for answering that question. And yes, you are correct. Their ABC Company cannot come in to HCPF and say, I'm a rideshare company. They have to be licensed through the Public Utilities Commission or PUC, like Adela stated, and they have much stricter licensing processes than even HCPF does at the moment. Does that answer all of your questions?
Dr. Kennard here, that was a terrific job of addressing those questions. And I'm very grateful. Just a little last one, though.
Mhm.
I guess what I was understanding is that not so much the Denver Health example, but some person in Sterling who just can't get, there is no NEMT out there to take them wherever for their visits, who otherwise would straight out miss the visit, which is we're trying to fix that problem, and I'm all for that.
Mhm.
But it strikes me that there are visits that are not happening and trips that are not happening now that now will happen, which is a good thing, but I can't imagine it's going to be for free.
This is Courtney Seaton. It's not an increase in trips, but you are correct. There are rural areas in Colorado that do not have a lot of NEMT providers. The good news is with the new broker, we've got a lot of excited providers that were not able to work through the previous broker that are now. And when they go statewide, they are willing to go a little bit further if we need. Or, as you just said, in maybe Sterling, Ron is an Uber driver and he sees that, oh, the department has signed up with Uber and Lyft. I want to sign up with Uber Health and I'm going to take all of my neighbors to their appointment. So that's absolutely something that could happen in these rural communities. They just need to enroll with Uber Health rather than just being a traditional Uber driver. And that's something they can absolutely do through Uber to help our more rural communities. And they would then, in essence, become that area's NEMT provider unless another company comes in or wants to serve that area, the state.
Dr. Kennard, thanks again. I'll just repeat my usual plea. Tell me in a year how much we've paid Uber and Lyft.
Okay. This is Courtney Seaton. We will happily come back and give you those figures.
Hughes, I think you got a question.
Jarrett Hughes, my questions were actually answered. They were around kind of paratransit training and accessibility issues. And it sounds like Courtney got at that. So thank you.
Any other questions or comments from the board? Mr. McLaughlin?
Thank you, Mr. Chair. Jason McLaughlin here. Just one follow-up question, Courtney, not directly related to this, but parallel to this. It's my understanding, I've heard recently that folks that are doing NEMT transport, if they're, say, picking somebody up at a doctor's office and bringing them home, it's not allowed for them to stop and pick up medications for that patient or to help that patient pick up medications or anything like that. Is that true?
This is Courtney Seaton. Thank you for that question, James. That is not true. And I've actually heard this over the last week or so. No, pharmacy trips are allowed under non-emergent medical transportation, and that can be from their home if they have to go pick up meds or get a vaccine or whatever it may be. And that also is from coming from a hospital discharge, their doctor's office, wherever. If they were given a prescription, they can make that stop to pick up their needed medication and then go on their way back home.
I really appreciate that clarification. I think that is so valuable, as you know, when we talk about addressing social determinants of health. That is, so thank you for that.
Thank you.
This is Amanda Jashinsky. Courtney, can I piggyback off of that question and Dr. Kennard's questions? First is, if they're going to make an additional stop, then do they have to get it approved in advance? That would be my guess, just the way things work. And the other reason I say that is because Uber makes you do that. So if an Uber driver is stopping anywhere along the route, like if you're going to work because your car's broken and you're like, actually, can you pull over at Starbucks? You actually have to, like, the Uber drivers are not allowed to veer off the route. The app will flag if they're doing that. So all those stops need to be pre-approved in the trip. So that's just a comment question.
This is Courtney Seaton. It's a great one. You are correct. And with the systems, the NEMT digital systems that the new broker is working with, they do work similar to what we think of as Uber and Lyft, although the member themselves is not the one in there fiddling around like we would when we're requesting a trip, but it is the same. The good news about MediDrive is that they are very, very tech savvy, and they actually work with a number of transportation systems. So it's not just they're all linked into one. Yes, they need to add in that additional stop during the trip, but they don't need to like halt the trip. I think that might be what you're asking, to get pre-approval or permission or anything. I spoke to MediDrive about this because there was confusion around the pharmacies last week. And so we've cleared that up, but it would in essence work how you're thinking, Amanda, through the app, but it's not going to hold up the member from getting back home or getting their medication or anything.
Okay, and then I have kind of another comment question for Dr. Kennard's concerns, which are very valid, I would say, of like, you know, abuse of the system, fraud, and all of that. I think I'm speaking as a millennial, but like I'm kind of reassured by the use of groups like Uber or Lyft because they have built in, like, again, you can't, like a driver can't decide to make the trip take 45 minutes the way, you know, they used to do to you in like an old taxi cab when you didn't know the city, because if they veer off route and there's a pre-approved amount that the route is going to cost, then the app kind of flags that that's happening. So my guess is that they're going to use the same tech. But then to Dr. Kennard's kind of question of knowing how much we're paying, you know, a third party, is that something that you guys would track or not really, because MediDrive would be tracking all of that as the broker? Like, is it our concern, I guess, is my question, because if we're paying them a flat fee to just deal with it, then they decide whether Uber's abusing the program or not, right? Like if Uber's charging them too much, isn't that their role as a broker to be like, hey, Uber, you got to calm it down? Or is it the department's role to have to deal with that level of detail, I guess is my question.
Thank you. This is Courtney Seaton again. So I think there's some confusion around how Uber Health and Lyft Health will be paid. I have met with them extensively for years. I've been trying to make this happen, so I'm very excited that we are here today. They actually have agreed to our fee schedule. So we're not, like when we all think of Uber and Lyft and the flat fees that we see, when we call for a trip. That's not how this is going to work. They are being paid exactly like all other NEMT providers are for our fee schedule. So the mileage is the same, base rate's the same. There is no surge pricing. There's none of that stuff that we see when we, as just going about our days, see with Uber and Lyft. It's a different program, and they are paid just like all other NEMT providers are from our fee schedule. Did I answer
Yeah, I
all of
think
your...
that answered
Oh,
it.
and you
I mean,
asked about oversight, I
well, I
think.
guess I was wondering what part you oversee in terms of that fee schedule versus your broker. Because to Dr. Kennard's point, he's wondering how much might be going, understandably, to these organizations that could want to take advantage of the opportunity of providing rides, right?
Okay,
So,
understandable. This is Courtney Seaton again. Again, they're going to use the fee schedule, so there's no additional payment to the third parties. They're treated just like all other NEMT providers. And you asked about the oversight. The department is the number one oversight. It is our job to be great fiscal partners and oversee our programs and our benefits. We are excited to have MediDrive in place because with them and their tech, like you mentioned, Amanda, we have much better capabilities of tracking the spending. As you said, these drivers are using digital programs now, and they can't just veer off and take the scenic route to get to wherever it is that they're going. They are the ride is put into the system like it is on an Uber and Lyft, but this is even for just our traditional NEMT providers now, and they have to follow that route. Obviously, the more rural areas sometimes will have weather or bridge out or something, and we, the department, have made some exceptions and rules around what happens in those cases. But overall, our oversight is going to be so much better than it has been in the past. So this kind of runaway spending we are hoping is a thing of the past, not for the future.
thank you.
Dr. Kennard here. First of all, I agree with my millennial colleague. I'm actually enthusiastic. Nobody keeps more data than Uber and Lyft, and so there'll never be an excuse for them not to be able to provide exactly what and where their drivers went. So there should be some built-in accountability there. So I'm done with my questions. Let's see how it goes.
Thank you.
Any other questions or comments from the board? Mr. Sykes, do we have anyone signed up for public testimony?
This is Chris Sykes. As of before 9 a.m. this morning, we did not have anybody signed up for testimony on this rule.
I'd like to speak. I emailed you.
Yeah, I know, but at 9, this is Chris Sykes at 9:46. Testimony shuts down at 9 a.m.
All right, with that, I would accept a motion for this rule.
This is Amanda. I can do the motion.
I move the emergency adoption of document B MSD 26-01-29-A, revisions to the Medical Assistance Act rule concerning non-emergent medical transportation rideshare authorization. Section 8.014, incorporating the same benefits with the purpose and specific statutory authority contained in the records.
Is there a second?
This is James McLaughlin. I will second that.
All in favor?
Hi.
Aye.
All opposed? Any abstentions? Measure passes. Thank you. We'll now we'll move on to the final adoption by a consent agenda. Do any board members have any desire to pull anything off of the consent agenda? Seeing none, do we have any public testimony on?
This is Chris Sykes. No, I'd just like to point out that the June minutes are included in the consent since you guys asked for that last month.
Great. So I would accept a motion for the adoption of the consent agenda.
This is James McLaughlin. I can take that.
Thank you.
I move the final adoption of the June 12th minutes, document 01 CHP 26-05-03-A, revision to the medical assistance rule concerning CHP plus, removing coverage limitations per final rule section 210I. Document 2, CHP 2602-09-B, revision to the medical assistance rule concerning HR1 amended definition to qualified non-citizens, section 110.1.B. And document 03 MSB 2602-09-A, revision to the medical assistance rule concerning HR1 amended definition to qualified non-citizen, section 8.100.1.G and 8.100.4.G, incorporating the statement and basis and purpose and specific statutory authority contained in the records.
Thanks so much. Is there a second?
This is Kathy Littler, I second.
All in favor?
Aye.
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 Oh. Any abstentions? All right, passes. We'll now move to our initial approval agenda and document 4. Who's going to be presenting on that one?
This is, I believe we have Erica Shaler with us.
Yeah. Okay, you ready for me?
You are, yeah.
All right. My name is Erica Shaler. I'm a compliance and policy advisor here at HCPOP, and I will be presenting MSB 25-12-10-A, revision to the Medical Assistance Act rule concerning immunizations, sections 8.200, 8.700, and 8.800. Presenting with me today will be Christina Winship, who's here to answer any of your policy questions that you may have. Immunizations are vital to the health and well-being of Coloradans by reducing the number of individuals impacted by vaccine-preventable diseases. More widespread vaccination uptake increases the numbers of individuals with immunity or resistance to these illnesses, many of which can otherwise cause serious and lasting health impacts. Recent changes to federal policies have created confusion about which vaccines should be administered and at what time intervals for children and adults, and have raised questions about whether these vaccines are covered. This rule adds the term medically necessary to the immunization rule, as well as incorporating the 2026 American Academy of Pediatrics, or AAP, immunization schedule. The current rule references only the Advisory Committee for Immunization Practices, or ACIP, immunization schedule, which recently has undergone changes that have departed from AAP recommendations. In order to ensure Health First members have access to all medically necessary immunizations, the department is adding the term medically necessary and ensuring both schedules are included. So this rule is intended to maintain coverage. Any questions from the board? Thank you.
This is Kathy Littler. I have a couple of questions.
Go ahead.
This is great, and thank you so much for thinking about children across Colorado and vaccine prevention of really some terrifying diseases. One thing I wanted to ask is that I appreciate that it incorporates the AAP 2026 schedule, but I wonder if there's room for adding in things like the American College of Obstetricians and Gynecologists, or things like maternal RSV immunization, as well as the ACP guidance for adults who are on Medicare. I think House Bill 251027 had some language in it for the Board of Health rules, and so I don't know if maybe we could mirror that just to make sure that it's not just kids.
Christina Winship for the department. I believe the language is not limited to those things, but all medically necessary vaccines. And the American Academy, this isn't limited to children, to be clear. We're trying to encompass broadly kind of as much as we can.
Great. So I think I would just maybe in the next version of the rule consider adding the other schedules on there, because the AAP vaccine schedule or immunization schedule is just for children. and doesn't include those things like the maternal immunizations. So just something to consider. And then I have a second question, if that's okay. I think I understand why you're using the term medically necessary, but maybe you could elaborate on that terminology, maybe in terms of that way it's then covered under EPSDT is my sort of thinking. But just wondering what a medically necessary immunization is.
This is Christina Winship with the department. There's many reasons for using the term medically necessary. It aligns with our authority under our state plan. It aligns with our federal responsibilities under EPSDT. We also just, right, generally as Medicaid have an obligation only to pay for medically necessary services. We are also prevented from covering vaccines that are purely for the purposes of travel. So that all of those factors together contribute to the use of that word choice, medically necessary.
Thank you, Christina. This is Cassie Liller. So it just gets tricky because of how terminology is in terms of shared decision making and medically necessary. And I don't want to get too technical here, but you know, I would consider all immunizations on the AAP schedule medically necessary. And so I guess who makes that determination of what is a medically necessary immunization?
This is Christina Winship for the department. Yes, we largely defer to providers, right? Okay. There are definitions of medically necessary in our regulation, and that's what we're calling back to. We, you know, at a certain level have to defer to providers to interpret those regulations and make decisions in accordance with standing definitions.
Great, thank you for that. And so this is Cassie Littler, does this then allow, if the Vaccines for Children program no longer covers, for instance, the hepatitis B vaccine in the future, this would allow the state to then cover it under general funds?
This is Adela Flores Brennan for the department. I think by using the terminology medically necessary, we're both getting at this idea, the concept that Christina noted about, you know, not covering travel vaccines or something, but also trying to be as expansive as possible in light of what is happening at the federal level. Now, in terms of being able to shift to general fund only, hopefully this has the flexibility in the rules so that we wouldn't have to come back, but that would be a budget decision that we would need to take to the state legislature. So I wouldn't say that that would be a guarantee or an automatic thing, but at least we wouldn't necessarily have to come back for a rule change. And then I also wanted to recognize in the room is Dr. Lisa Rothgary, our Chief Medical Officer. And so we'll cede any time if you wanted to jump in on any of this.
That was all perfect. Thank you both.
Great. Other questions or comments from the board? Seeing none, Mr. Sykes, do we have anyone signed up for public testimony?
This is Chris Sykes. I do not have any testimony signed up for this rule.
With that, I would accept a motion to approve this rule.
It's Kathy Littler. I would like to do that and move the initial approval of document 4 MSB 25-12-10-A, revision to the Medical Assistance Act rule concerning vaccines, sections 8.200, .700, and .800, incorporating the statement and basis and purpose and specific statutory authority contained in the records.
Is there a second?
Amanda, I second.
All in favor?
Aye.
All opposed? Any abstentions? The rule passes. On to document 5. And I think we have Christine Bates for that one.
Good morning, Mr. Vice Chair and members of the board. I apologize, my name is not up there. I did change it at one point. So I think the meeting has taken over. I am here, I'm sorry, I'm Christine Bates. I'm the Supported Living Options Unit Supervisor for the Office of Community Living. And I am here to present MSB 260409-A. If you can move to the next slide, please. So we are talking about an enforcement regulation for nursing facilities, section 8.482.45. And what we have done is added civil money penalties and interest to this section for the nursing facilities. Civil money penalties may be added to nursing facility recoupments after audits that are being conducted by Healthcare Policy and Financing. Next slide, please. We've always been able to do this through this statute listed on this screen, but it was never put into the regulations. So we're adding it to the regulations so that we can do this, excuse me, through the recoupments if it's necessary. We're hoping that we don't have to, but we have had some instances where we've needed to. This has gone through the legal team and through the Attorney General's office for review. Next slide, please. The reason we're doing this is because of all the federal looking at fraud, waste, and abuse and compliance, and also because of reviews that have been completed in our office. We've seen some high error rates and some large dollar recoupments and various compliance issues. So we wanted to get this into the regulations so that we could use the civil money penalties when we needed to. Next slide, please. I do want to point out that these are different from the Colorado Department of Public Health and Environment surveys that are performed, where they will use the civil money penalties. So these will be completely different from those surveys that are conducted by CDPHE. Next slide, please. And these can apply to both nursing facilities and intermediate care facilities. Next slide, please. And the reviews are not limited to just medical records. We do reviews on cost reports, surety bonds, and other types of reviews that are completed, especially personal needs accounts and change of ownerships. Next slide, please. So some common errors that we see across the reviews are listed here. I'm not going to read all these to you, but we definitely see some issues with all types of missing documentation or other errors in the documentation. Next slide, please. We can also apply interest to payments that are not received in a timely manner. And this is in the statute, and it's currently at 8%. And again, we would only use this if it became necessary. Next slide, please. As always, there's a process for the nursing facilities to ask for reconsideration and for an appeal, just in case there was some type of miscommunication. Next slide, please. And if you were to have any further questions, you can contact myself or Kathy Fielder, who does the audits. And I believe that is the end of my presentation. Are there any questions that I can answer for anyone?
Questions from the board, Mr. Hughes?
Hi, Christine. This is Jarrett Hughes. Is it safe to say that, given that you already have the statutory authority, this doesn't necessarily change much in practice or operationally with regards to kind of our current work with the nursing homes?
This is Christine Bates. That is correct, Mr. Hughes. Thank you for that question.
Any other questions from the board? Mr. Sykes, do we have anyone signed up for public testimony?
This is Chris Sykes. I do not have anybody signed up for testimony on this rule.
With that, I would accept a motion for document 5.
This is James McLaughlin. I can take that.
Thank you.
I move the initial approval of document 05 MSB 26-04-09-A revision to the medical assistance nursing facility reimbursement rule concerning enforcement by the department, section 8.482.45, incorporating the statement of basis and purposes and specific statutory authority contained in the records.
Thanks so much. Is there a second?
Jarrett Hughes at second.
All in favor?
Aye.
Aye. Aye.
All opposed? Any abstentions? Document 5 passes. Document 6. Diane Lamb.
Hi, can everybody hear me?
Yep.
Hello, can you hear me?
Jan, thanks.
Oh, okay, thanks. Good morning, Mr. Vice President and board members. My name's Diana Lamb, and I'm the Inpatient Hospital Rates Analyst for HCPF. I'm here to present MSB 2510-29A, which contains the revision to the rule authorizing payment for inpatient services in section 8.300.5. Next slide, please. So just first off, this is a purely housekeeping rule where we're just fixing some language to be more clear. And budget impacts, hospital payments, nothing changes. Next slide, please. So sections 8.3005A and 5A5 is being updated to fix the alphabetical peer group references and add clarity that border state hospitals are assigned to an in-state peer group based on geography. Again, the nature of both these changes is simply housekeeping in nature and represents absolutely no change. It's just clarity. Additionally, we reviewed these changes, and you'll see on the next slides, with hospital stakeholders during our November 7, 2025 hospital engagement meeting, providing 30 days for stakeholders to register any concerns. We never received any. Next slide, please. These are screenshots of the actual slides that we did present to our hospital stakeholders. We meet with them every other month. Next slide, please. So I just wanted to let you know that the AG's office made several grammatical changes and requested we tighten up language for a portion of rule that we weren't changing, that where we reference CMS's Medicare rules detailed in 42 CFR 413.75. We had exec language in there that was pulling in the entire subpart F of Medicare's rules. And they wanted us to tighten that up and only refer to the graduate medical education, GME portion. So what we did was we made that change pursuant to their request. And again, it doesn't change anything. Hospitals are required to follow Medicare rules when they are putting together their cost reports, which is what we use for graduate medical education and many other things in inpatient hospital payment. Next slide, please. Oh, and I should say, I have on there for July 10th, we got the AG's request to make those changes. And like I said, we meet with our hospitals every other month. So we were not able to preview that, but we will be telling them about that this afternoon. I really don't expect anything. All we've done is shorten the list on that. It was included to begin with. So again, it's really not any sort of change. It's just clarification. And that's all I have. If you have any questions, I'm happy to answer.
Any questions or comments from the board? Mr. Hughes.
It's my first day, but I tried to come prepared. And admittedly, I we had just walked out of the room, so I apologize for this, but how many hospitals do you expect this to impact? Just curious.
It impacts all hospitals in that peer groups are assigned to hospitals that affects the rates that they're paid. This represents no change. Hospitals will be paid exactly the same way they were paid before this change. So again, all these changes are just clarification in the rules. Our life and hospitals' life is much easier when we're very clear. So that's all this is doing, is updating the rule.
Okay.
Any other questions or comments? Mr. Sykes, do we have anyone signed up for public testimony?
This is Chris Sykes. I do not have anybody signed up for public testimony on this rule.
With that, would anybody like to make a motion on document 6?
This is James. I could take that one.
Thank you.
I move the initial approval of document 06 MSB 25-10-29-A, revision to the inpatient hospital payment rule, housekeeping updates to section 8.300.5.A and 8.300.5.A.5, incorporating the statement and basis and purposes and specific statutory authority contained in the records.
Thank you. Can we scare up a second?
This is Amanda, I second.
All those in favor?
Aye.
Opposed? Abstentions? Motion passes. All right,
Can we take a break?
sure. 5-minute break.
Email.
Perfect.
All right, welcome back, everyone. We're moving on to document 7. And let's see, who do we have presenting on document 7? Cassandra Keller.
Good morning. Can you hear me okay?
We can hear you just fine.
All right. Well, good morning, Mr. Vice President and members of the board. My name is Cassandra Keller, and I'm the Community Options Benefits Section Manager within the Office of Community Living. I'm here today to introduce document 260302A for initial approval. This rule package includes revisions to 2 sections of our regulations. The first change is the Provider Agency Accountability Rule for Marketing, Conflict of Interest, and Outreach. And the second change is clarification related to in-home support services backup support. Next slide, please. The primary purpose of the Provider Accountability Rule is to establish clear and enforceable standards for how home and community-based services and community first choice provider agencies market, communicate, and engage with Medicaid members, their families, caregivers, and our case management agencies. This rule is about protecting member choice and making expectations clear for provider agencies. This rule limits unsolicited contact, prohibits inducements tied to provider selection, and prevents improper influence over eligibility or service authorization decisions. It also requires communications to be accurate and truthful, including statements about Medicaid eligibility, available services, and caregiver compensation. Importantly, the rule also clarifies what provider agencies may continue to do. Overall, this rule creates transparency, accountability, and consistent expectations across our HCBS and CFC provider agency practices. Next slide, please. HCPF developed this rule because of concerning provider practices that have been in existence. We've seen marketing and outreach practices that confuse members, pressure them to choose or switch providers, or improperly influence the eligibility process, assessments, service planning, or prior authorization decisions. We want members and families to receive accurate, plain language information about their services and their options. We also want members to receive the care and support they need and to be able to accurately describe and document their needs during assessments, care planning, and service authorization without pressure from provider agencies. At the same time, we need to make sure members are not unduly influenced, misled, or offered incentives to choose or change providers. Provider selection should be based on service offerings, not inappropriate incentives. Services should be authorized based on assessed and documented needs, not pressure or misinformation. Clear rules support appropriate service use and responsible spending of Medicaid funds. The goal is not to limit access to needed services. The goal is to support accurate information, appropriate authorization, and program integrity. This rule creates a clear line between what is helpful to members and what is not appropriate behavior by provider agencies. Next slide, please. The rule sets clear expectations for provider agencies. Provider agencies may not mislead or pressure members or their caregivers. They may not offer incentives tied to choosing or switching providers. They may not use unsolicited direct contact for marketing purposes, improperly influence service decisions, or coach someone to exaggerate or misrepresent needs. At the same time, we are clear about what they can continue to do. They can provide factual education, answer questions, participate in care coordination, share documented care needs, help members accurately describe the care needs when they're asked to participate in the person-centered planning process, and participate in that process with the case manager when requested. This distinction is important. We don't want to prevent self-advocacy, education, routine care coordination, or appropriate provider participation in planning. Instead, we're trying to prevent pressure, misinformation, exaggeration, and improper influence by provider agencies. Next slide, please. This document also includes a revision related to in-home support services, or IHSS. Colorado's current statute requires, and our regulations require, IHSS, in-home support services, agencies to provide 24-hour backup services. This is absolutely not a new requirement. As I mentioned, it's in statute and it's been in rule for years and years. It's a requirement not only for HCPF regulations, but also required for licensed Class A and Class B provider agencies through the health department. What this rule is aiming to do is clarify that backup attendants must be employed and supplied directly by the IHSS agency, rather than provided by the family member. Members, authorized representatives, and family members are not responsible for providing or securing agency backup attendant support. It's the responsibility of the provider. This clarification is intended to support continuity of care and make responsibilities clear for IHSS agencies, members, families, and case managers. Next slide, please. Stakeholder engagement has been an important part of developing the provider accountability regulations. The department shared first drafts of these rules in January 2026 and received more than 80 written comments and submissions. A revised draft was released in March for additional review, and the department provided another opportunity for public comment before bringing it to you. We've also met individually with affected stakeholders and organizations that requested meetings. These conversations helped us better understand concerns and identify where the rule language needed to be clear or more workable. One thing we heard was that members should receive clear, accurate information about their options. Provider agencies should be able to give members, families, caregivers, and case management agencies factual and understandable information about services, provider responsibilities, and member rights. We also heard that provider choice should not be shaped by undue influence, promises, or incentives. Members should choose a provider based on their needs and preferences, not because of sign-on bonuses, rewards, gifts, or promises tied to selecting a specific agency. Another theme was that services should be based on assessed and documented needs. Provider agencies should not influence that eligibility, service authorization, or care planning decisions in order to increase services or steer members towards a particular provider. Stakeholders also asked the department to preserve appropriate provider communication. In response, the rule makes clear that provider agencies may still provide factual education, participate in routine care coordination, and support person-centered planning when requested and properly documented. Lastly, stakeholders expressed concerns that in-home support service agencies would not provide backup caregivers, that in order to have backup care, the member or family needed to provide an alternative caregiver to perform this work. Stakeholders requested stronger regulatory language to address this issue and the concerns that they were having. Stakeholder feedback was carefully reviewed and directly shapes the rule before you today. Next slide, please. The stakeholder feedback helped make the rule clear and more workable. Definitions were clarified so expectations are easier to understand. Allowed activities are clear, including education, care coordination, and support with accurate documentation of needs. Compensation protections were strengthened for referrals and for enrollments transfers, and other HCBS Medicaid business. Documentation requirements were narrowed so routine care coordination is not treated as marketing documentation. And all of these changes were intended to keep the rule focused on the conduct that HCPF is trying to prevent while preserving appropriate communication and support for members. Next slide, please. In summary, the rule revision does several important things. First, it establishes clear standards for provider agencies around advertising, marketing, conflict of interest, and outreach. It protects member choice and access to accurate information. It clarifies what provider agencies may continue to do, including education, care coordination, and planning support. Lastly, it clarifies how IHS agencies are responsible for backup attendance support, so members, authorized representatives, and families are not left responsible for arranging backup coverage. The department recommends initial approval of this document, and I welcome any questions.
Any questions from the board?
Mr. Chair, James McLaughlin, just a comment.
Go ahead.
Again, Cassandra, I think this honestly, in a lot of ways, gets to the heart of the problem that we've been talking about for several months now. I think this is spot on. I support this wholeheartedly. I've said it before. I think there's a few bad actors out there that are endangering these services for a lot of folks. And I think that these rules help start down the right path to correcting that. So thank you very much. And I support this.
Any other comments or questions from the board?
Dr. Kennard here. First of all, yes, I would echo Mr. McLaughlin's comments. I'm enthusiastic about this kind of approach. Could you take a second to respond to the testimony from, let me see, that we received just Wednesday evening, that made it sound like this person was concerned that this would sort of put a extra burden on, somehow a burden might shift to the actual, not the care provider, but the person in the home. Do you know what I'm referring to, Cassandra?
You're on. Yes, sorry. I do, Dr. Kennard. Thank you. This is Cassandra Keller. I can appreciate the written and testimony that we're going to hear today. But I want to be clear that this IHSS backup requirement has been in statute since, I believe, 2002. It has always been a requirement to have this backup care. It is one of the main tenets of the in-home support services benefit, of why a lot of families choose to go with that, because it does have that backup requirement. The trend we've seen recently in the last several years is that provider agencies, IHSS provider agencies, will say, well, we can't accept you unless you bring a caregiver and a backup care provider. And so it's really making that service inaccessible and inappropriately putting the burden on the family when it's the agency's responsibility to have that backup care. So that hasn't changed, but the operations of how provider agencies have been doing this and shifting that burden to the members. So we want to clearly state that that burden is not on the family to provide a caregiver and a backup caregiver, that it's the agency's responsibility. So we feel like it's really important that not only do we say that backup care is required, which is already in rule and statute, but that requirement is of the provider agency. So, it's really just clarifying what that responsibility is. And so I don't see how that's going to shift that responsibility back to the family. Instead, it should be putting it squarely on the shoulders of those IHSS providers. And I can understand that folks might feel like this is not, that these are two separate rules, but really they're both in the same vein. We are working to require accountability for these provider agencies, make sure that they're acting appropriately and within the regulatory requirements. And backup care is a requirement of that IHSS benefit. So we feel like it really fits nicely in with this regulatory set of provider accountability.
Dr. Bernard here. Thank you very much. That's very helpful.
McLaughlin?
Thank you, Mr. Chair. Cassandra, that rule change specifically, doesn't that align with the rules that already exist in CDPHE, I believe in chapter 27, that state that the agency providing the services is responsible for providing backup, and they can't offer the service unless they can do that, correct?
Yes, Mr. McLaughlin, this is Cassandra Keller, and you're absolutely right. So, things get a little complicated for an IHSS provider agency. They are licensed as a Class A or B home care agency. And per Chapter 26 regulations, you are correct. They do have to provide adequate staffing. And that means that if you're going to accept someone into your services, then you need to be able to meet their needs. And that includes staffing and backup staffing. So absolutely, this is required by statute, it's required by their license, it's required by us in our regulations, but there's just been some, not all of these provider agencies are doing this at all. There is a handful that are doing this kind of pressure to bring your own care provider. And so we really want to nip that in the bud and make it clear to those actors who are acting inappropriately that you cannot put that burden on the families, that you need to take that on as a responsibility. So it's clarifying and reinforcing what is in rule and trying to kind of cut down on those kind of skirting of the rules, if you will.
Chapter 26, sorry. Thank you. Yes, thank you very much.
Dr. Littler.
Hi, this is Cassie Littler. I just had a kind of a clarifying question. So if a family does have a backup provider that they wish to use, there's still an opportunity for that family to make sure that that backup provider is credentialed with the provider agency in order to utilize them as a backup. Is that correct?
This is Cassandra Keller. And yes, absolutely. You can absolutely take your, and lots of people do. They have their normal provider and they have a backup care provider, and they are more than welcome to work with an agency to have. What we don't want it to say is, hey, we can't accept you unless you bring all the staffing that is needed. We're not going to provide any form of assistance. It's all on you. That's what we're really trying to prevent. But if you have folks that you want, absolutely, I think the agency would be more than happy to take you on. It's just there's a lot of trying to skirt that responsibility to provide the care and requiring that you must bring staff with you. That's what we're trying to cut down on.
Thank you.
Yeah, I had a clarifying question. This is Jarrett Hughes. Staying with the IHSS component, there's a language added around attendants must be employed and supplied directly by the IHSS agency. I was curious how temp staffing looks with IHSS providers and if like temporary or contract staff would be eligible under that language.
Good question. And there is a lot of independent contractor work throughout our home and community based and community first choice benefits. But I believe for IHSS, they do need to be employed. And I think that might work for temp staff, but I don't believe that typically we're not seeing independent contractors under that benefit just because of the way the agency model is.
And that makes sense. I'm more familiar with it in like the CNA skilled nursing world. So
yeah,
curious how that might overlap.
Some of these agencies, I mean, they're licensed in the same way and operate in the same way as those, because they're Class A or Class B as your skilled nursing agency. So typically they're not operating and utilizing those independent contractors.
Thank you.
You bet.
Dr. Littler.
I have a comment. This is Cassie Littler. I would just continue to say if we could make sure throughout all of our rules that provider is like really clear as to what that means, because it just gets so confusing for all the different types of providers as well as for families. So just making sure we're being really clear about that. Just, makes sense, a provider agency, but again, just one thing to consider.
Thank you, Dr. Littler. I 100% agree. I think I try to really hard to make clear that we're saying provider agency because provider could mean a physician provider. It could mean the provider of the direct care, which is technically a caregiver. And those terms can often be conflated. So we really want to make clear that when we're talking about an enrolled entity that is the overall accountable entity that's responsible for care, we're talking about an enrolled provider agency. So I can appreciate the need for clarity there.
Thank you.
Any other questions or comments from the board? Seeing none, Mr. Sykes, I think we have people signed up for testimony.
We do. And first up for testimony is Maureen Welch.
Great. And is this the microphone here? That's. Do I have a timer or?
2 minutes.
You don't have a little one like at the Capitol?
Okay.
Oh, up there?
Well, Kelly, are you gonna throw up a timer for us?
Once Maureen starts her testimony.
Thank you for the opportunity to speak, Mr. Chair. I have 4 points on this rule, specifically on the provider agency, marketing, conflict of interest, and member outreach. I agree with the intent of this rule packet and to eliminate the cash or gift incentives for members to change providers. I know of agencies that offer $5,000 for people to move over, and I don't think that's appropriate. However, due to my policy work at the Capitol, HCPF, and many other places, I always consider the unintended consequences that may happen. I have concerns because a lot of the families that I work with do need support. They do need advice from their provider agencies. And I worry that we're creating an atmosphere of fear for our provider agencies that if they do give guidance of any type, they are putting their agency at liable risk for being accused of coaching. We have huge turnover in our case managers. They're thin, they're overworked, they're underpaid, and we cannot rely on them as a community for sources of advice. We really look to our provider agencies who honestly are more experts in that particular service than a generalist as a case manager. Agencies, I'm also concerned about the lack of clarity about what is educational and what is considered exaggerated. This is not clear in this rule. In this very competitive market, people could make complaints and weaponize this against their competition, and then, make it easier for them in their market. What also concerns me is that if there is a violation or a complaint made, this rule doesn't offer or doesn't appear to offer any appeals or hearing rights to a provider when they are wrongfully accused. So thank you for your consideration, and I appreciate being here in person today for a change.
Any response from the department?
Thank you, Dr. Martin. Are we doing comments after each testimony, or do I wait to summarize at the end? I know we had shifted last month.
At the end, okay, sorry about that.
That's okay. Okay, I will hold my comments then.
All right, Mr. Sykes, I think we have another person signed up.
This is Chris Sykes. We have Nicole Vilas.
Good morning, members of the board. Can you hear me okay?
Yeah.
Okay. My name is Nicole Villas, and I am a caregiver for a high needs adult with IDD. I volunteer and advocate for adults with his condition, which involves very high needs. I'm testifying in support of about 97% of this rule. The provider behavior, the outreach, the marketing, all wonderful, great, pass it as is. I actually only have a problem with 2 lines on the last page of the rule. The last page of the rule deals with something that Cassandra didn't actually mention once in her presentation, and that's adequate staffing. So the regulations right now do say that provider agencies must provide backup care, and we have no problem with that. They absolutely should. Nobody wants members to go out without emergency care. But this lines, it's like 23 to 24 of the last page, go further than that and say they must have adequate staffing to meet the members' needs. If you had presented this rule last year, it would be fine. If you had presented this rule next year, it would probably be fine. Right now, in this environment, provider agencies have experienced essentially a 50% cut to their staff, given the 56-hour cap. And this part of the rule is in direct response to that 56-hour cap. And so it shouldn't be part of the provider behavior and marketing and outreach and conflict of interest document. And I believe that that's why it has flown under the radar. It's in the wrong document. It shouldn't be here. That those 2 lines of this last rule are in the wrong place at the wrong time, given the environment and all of the changes that IHSS agencies are navigating right now. when you think about high needs members, like my son, he doesn't do IHSS, so I don't have a stake in this, but the families that I work with do. When you think about them and their high needs, all of a sudden you have agencies saying, well, we had adequate staffing for you before because, you know, the parents or whatever provided 112 hours of care. Now that's going down to 56, and all of a sudden half the staffing is gone, and they fear they will be out of compliance with this rule because this rule tightens the language on adequate staffing. Before, in Chapter 26 of 1101, the regulations stated that you had to have reasonable assurance that the member's needs would be met. My time's up, but my concern is not with backup, it's with the staffing component.
Thank you so much for your letter and for your testimony. Mr. Sykes, who do we have next?
This is Chris Sykes. We have Kathy Feber.
Good morning. Can you hear me?
Yes, we can.
Hello, Medical Service Board members. Thank you for taking my testimony today. I am a family caregiver and advocate to a 26-year-old with Down syndrome, autism, and IDD on the DD waiver. I don't have a stake in this exact rule. However, I want to point out that 8.7528.h revision does not belong in the implementation of the marketing rules. These are two totally separate rules. 8.7528H was not properly addressed in your meetings, and I feel was added after a conversation I had with the director of OCL. I can't prove that because it's impossible to track the rules revisions without downloading each day and comparing versions, since HCPF doesn't put dates on any of the rules they draft. Please remove this part of the rule change before you vote on 8.7420 provider agency marketing rules. I will add that the CCD, along with HCPF, feels that there are all these people waiting to work in this field. I would ask that the MSB, along with other agencies, track the number of members they are helping to find additional caregivers and the success rate. You and HCPF should be getting reports of how many RFPs that go out there are fulfilled in the end. We see dozens each day, but the likelihood of them being filled is extremely low. On another note, I would say that I am disappointed in the governor's decision to let go of Laura Carroll. She was a wonderful president and advocate for our population and will be missed.
Thank you so much, Kathy. Mr. Sykes, who do we have up next?
This is Chris Sykes. We have Michelle Dumais.
Michelle, or you?
Can you hear me now?
There you are.
Perfect. Good morning, Vice President and MSB Board. We are providing testimony today to raise concern about the IHSS provision included at the end of this rule. First, this provision appears to be new. Unlike the rest of the rule, it has not gone through the stakeholder review and engagement described in HCPF's materials. Families, members, advocates, and IHS agencies have not had a meaningful opportunity to review this language or explain its real-world impact. Second, this provision will make an already difficult situation worse for members on IHSS, especially members with complex care needs above the 56 hours per week. These members may be dropped by their current agency and may not be easily picked up by another agency. Third, telling members to simply move to CDOS is not a real solution. CDOS enrollment can take months, even under the best circumstances. More importantly, IHSS exists for a reason. It was designed as an option for members who want some self-direction and choice in their care providers without taking on all the employer responsibilities required under CDOS. HCPF's own July 2025 publication describes IHSS as a service delivery option that allows HCBS waiver members to decide how much they want to direct their care and manage their attendance with additional support from the agency. Yes, IHSS agencies have been required to provide backup care, but backup care is not the same as building a full-time workforce for high-need members. This language shifts responsibility away from the person-centered IHSS model and places the workforce crisis squarely on provider agencies. The result will not be better care, it will be fewer agencies willing to serve complex members, more service disruption, and more medically fragile people left without stable care. This rule does not protect members, it puts them at risk. Thank you.
Thanks so much for taking the time to give your testimony. Mr. Sykes, who do we have next?
This is Chris Sykes. We have Rebecca Parkins. This is Chris Sykes. I am not seeing Rebecca Parkins in the attendees. Kelly O'Brien, are you seeing the same thing I'm seeing?
I do not see her as well.
Okay, we'll keep an eye out for her.
But in the meantime, we'll move on.
Yes, we will continue on. We have, this is Chris Sykes. We have Bryce Rafferty.
Good morning. Can you hear me?
We can, thanks.
Good morning, Chair and members of the board. My name is Bryce Rafferty. I'm here on behalf of the Colorado Cross Disability Coalition in support of the rule with some comments. Our organization supports this rule and appreciates the department's work with advocates and stakeholders thus far. We also support the department's effort to make clear that IHSS agencies cannot function only as pass-through fiscal agents while shifting staffing, backup care, and recruitment responsibilities to members and families. Family caregivers may step in during emergencies, but they should not be treated as the default solution to provider agency staffing failures. Our concern is implementation, however. Once an IHSS agency accepts a member, the proposed language requires that the agency maintain staffing capacity, plan for backup care, and communicate promptly if it cannot provide services consistent with the care or authorization. That is appropriate and consistent with existing IHSS rules. But with caregiver limits, LTSS sustainability actions, and the statewide direct care workforce shortage, some agencies may respond by refusing high acuity members or discharging members without adequate justification, and that cannot be the outcome. Provider accountability and caregiver limits are interconnected. Both policies depend on the same missing foundation: a stronger direct care workforce with skills, availability, and willingness to serve members with complex needs. CCDC supports this move moving forward, but the transition must be managed carefully. Provider agencies should lead recruitment and outreach because they are licensed and paid to maintain staffing capacity. Accountability must also prevent service gaps, unsafe discharges, and refusal of new high acuity members with the workforce while the workforce is rebuilt. Before final adoption, we urge HCBUF to convene a short, time-limited stakeholder process to define reasonable staffing efforts, recruitment expectations, backup care obligations, data reporting, and escalation pathways. The message to providers should be clear. The business model must change, but members should be protected while Colorado builds the workforce and accountability structure this rule requires. Thank you.
Thank you, Rafferty. Mr. Sykes, do we have the previous person or another person signed up for this?
This is Chris Sykes. We have Megan Bowser next.
Great, thank you. My name is Megan Bowser. I'm the Executive Director of Family Voices Colorado and also the parent of 2 children who rely on Medicaid waiver services. Family Voices Colorado supports the overall direction of this rule while also recognizing that thoughtful and well-executed implementation matters. While there are many amazing agencies working in the state, in recent years we have seen real problems with misleading marketing, aggressive recruitment, and agencies shaping conversation around service authorization. My Instagram feed is filled with ads from these companies advertising strictly for payment for family caregivers rather than a more well-rounded approach of providing assistance to individuals needing in-home care and offering both options to provide caregivers and to hire families to provide this care when that is desired. Families and individuals deserve accurate information, meaningful choice, and freedom from pressure. At the same time, provider agencies do have an important role in educating families, helping them understand available services, correcting inaccurate information, and participating in planning when the member wants them there. Most families enter this world of disability services with no formal training or understanding how systems like Medicaid work. With the recent shift to case managers taking a more gatekeeping role, it is important that providers are still able to appropriately support their clients and families. We also support the clarification around IHSS backup care. This is not a new requirement. It has long been part of what was supposed to distinguish IHSS from CDOS, but it has often not been followed. I have experienced that personally. When onboarding with a home health agency for IHSS for my son, I was required to identify who his backup provider would be. The agency did not provide that backup, and they didn't even offer to employ my identified backup provider. The responsibility was simply placed back on me. Then, when I had my own medical emergency and could not provide his care, it was still on me to coordinate backup care from my hospital room. That is not the meaningful agency support that was intended when the IHSS was first rolled out. I urge the board to move forward with this rule while ensuring implementation protects access, preserves appropriate provider involvement, and does not lead agencies to avoid or discharge members with more complex needs. Thank you.
Thanks, Megan. Mr. Sykes, do we have anyone else signed up for this rule?
This is Chris Sykes. We have Penny Rayleigh.
Hi, are you able to hear me?
Yep.
Excellent. Thank you so much for the opportunity to speak. My name is Hani Rayleigh, Executive Director of the Arc of Aurora, serving people with IDD and their families. We support the overall direction of this rule. That said, the rule would benefit from additional guidance and examples to providers, community organizations, and families to clearly understand where these boundaries exist. For example, some individuals need and require the support to identify and maximize benefits that they have been found eligible for. And that should not be considered coaching. It should be considered and approached as member education. Without the clarity, enforcement may be inconsistent and bad actors will continue to find ways around the intended rule. One area that deserves particular attention is the relationship between provider agencies and trusted community organizations. Advocacy organizations like the Arc of Aurora, family organizations, and other consumer-connected nonprofits are often viewed as neutral, trusted sources of information. We remain concerned that providers could attempt to use sponsorships, partnerships, or financial support to gain access or to influence members through those trusted relationships. We encourage the department to provide additional implementation guidance that addresses these situations and helps protect the integrity of independent community organizations while ensuring members continue to receive unbiased information from those that they trust. Finally, we appreciate the clarification that IHSS agencies are responsible for providing backup attendance, rather than placing the burden on members and families. However, person-centered care is about more than simply filling a shift. Many people with disabilities require attendants who are good cultural fits, understand their communication styles, respect personal preferences, or possess specialized skills. We encourage the department to allow members to decline backup staff who do not meet those person-centered needs without that being characterized as a refusal of service. Instead, those situations should be documented as workforce or provider capacity issues, a reflection that the system was unable to provide an appropriate person-centered match. Until Colorado develops a stronger workforce recruitment and retention strategy, we should be careful not to place the consequences of workforce shortages on people with disabilities. I appreciate the opportunity to comment today. Thank you.
Thanks for your testimony. Mr. Sykes, do we have anyone else signed up for this rule?
This is Chris Sykes. That ends testimony for this rule, and both Kelly and I have been looking for Rebecca Parkins. Unfortunately, she is not online.
All right, so now I think we would have a response from the department.
Correct.
All right, thank you, Mr. Vice President. This is Cassandra Keller. So got some notes trying to take address some of the concerns that were raised by the testimony. First, I just want to reiterate that, and this was mentioned a couple times, is that we absolutely agree, the department does, that provider agencies can be a wealth of information. They know services, like the back of their hand. They are on the front lines and can provide that information to members. What we want to make clear is that they're not influencing the process inappropriately. But if a member wants a provider agency to participate, provide them that information, they're always welcome to have that participation. They just need to be asked into that conversation. So they can't presume that that's what a member wants. The member just needs to request that. So I don't feel like there's going to be an area in where providers are going to not participate, feel like they're going to be penalized if they do. They just need to, make sure they have that permission from the member. Second point for something that Marie brought up is that it is true that we don't have due process to this in our rules, but we don't have due process for if you violate any of these regulations that we have in rule, we don't outline what that due process is. That due process is through, so a lot of these rules, CDPHE, the Department of Health, Public Health and Environment, they survey on these rules. They provide surveys on this. They document deficient practices, and there is a due process through them. So I would say if there is a due process, it is outside the scope of these regulations, and it's within that survey process with CDPHE. I know there's some concern with the term adequate staffing, but that's not new. And adequate, staffing is defined several different ways, depending on if it's something through the health department for licensing or HCPF. What we're really making clear is that you have the staff, when we say adequate, is that you have the staff to be able to meet the needs of the members that you're serving. You can't have nobody on backup, and then when a caregiver is out sick or unable to provide the care, there's no one there to do that. So we just want to make sure that members are able to get their care needs met, and that providers are providing that backup care. If there's a caregiver that's in backup that isn't culturally competent, doesn't speak the language, what have you, a member always has the option to decline care. They don't have to go with that caregiver. That's certainly their prerogative and option, but the provider agency still needs to be able to offer that backup care. I know there's concerns about the workforce, but we've been tracking how much the workforce has actually grown. In 2022, we had 28,409 direct care workers. In 2005, we've grown to 41,356 direct care workers. So we are actively working to expand the provider network, expand the workforce network, and not just rely on family members. We don't want family members to feel like they're in the situation that Megan described, where they're required to provide all the levels of care and they are in this alone. We want to make sure that the provider agencies are helping to support those families. We strongly believe that this portion of the rule does belong with this set of regulations. It is all tying to provider accountability. Providers need to act in the best interest of members. They need to support those members, and providing staffing is one of the very critical ways in which they do that. I understand that there is still some consternation about the 56-hour cap, but this rule is outside of that. We're asking that provider agencies, IHSS provider agencies, provide that statutorily required backup care. That is irrelevant to the 56-hour cap, in that those are two separate things that an agency needs to comply with. So if they can't staff under, if they need more caregivers because of the 56-hour cap, then they're going to need to recruit and get more caregivers as backup caregivers as well. We commit to working with stakeholders between now and the final draft on further defining that term adequate staffing, and absolutely we commit to working on implementation and operational guidance. I know that is going to be critical. Providers are going to want to have examples so they know how to what our expectations are. So we absolutely commit to working on providing that type of information. I think I covered all of the points, but I'm happy to field any additional questions.
Any other questions from the board? There are none. Is there a motion to approve document 7?
This is James McLaughlin. I can take that one.
Thank you, Ms. McLaughlin.
Absolutely. I move the initial approval of document 07 MSB 2603 -02-A revision to the Medical Assistance Act rule concerning home and community-based services, HCBS, and Community First Choice, CFC, provider agency marketing, conflict of interest, and outreach in home support services, backup support, incorporating the statement and basis and purposes and specific statutory authority contained in the records.
Thank you. Is there a second?
This is Jarrett Hughes, I'd second.
All in favor?
Aye.
Aye.
All opposed? Any abstention? Motion passes. It seems to me that documents 4, 5, and 6 would be appropriate for the consent agenda. Document 7, probably not. Does anyone feel differently? I concur.
Right.
All right.
Thinking about the document 4, if there is any updates to that, could that be pulled?
Fine, take it off consent. Okay.
Just 5 and 6. This is
Correct.
Chris Sykes. 5 and 6 on consent.
Yep. Thanks. Any other thoughts on that? All right, so we'll move on to the closing motion. Move that all rules adopted at this meeting of the Medical Services Board of the Colorado Department of Healthcare Policy and Financing meet the criteria of the State Administrative Procedure Act, which are incorporated by reference. If someone would second.
Kathy Littler, I second.
Great. So I believe now we are moving to open forum.
This is Chris Sykes. That is correct. And due to my not posting the open forum option box on the form, Kelly has opened raised hand for the participants if they would like to provide public testimony. I'm aware, Maureen, that you had said that you would, right? I just haven't received any emails as of yet. So if there's anybody on the call, they can raise their hand. But we do have 2 individuals signed up for public testimony in the open forum. So we'll call on them first and then we'll watch for raised hands. But first up is Maureen Welch.
Thank
Thanks,
you.
and again, with 2 minutes.
Okay. And where is the timer? I don't see it.
It'll begin
And when I
on
looked
the
up
TV
the,
on your right, and it kind of goes, there it is, right next to
so
above,
small.
don't show this
yeah,
again.
I need an accommodation. My 58-year-old eyes cannot see that. Is there a way, or something on the
I can
table?
just do the.
Oh, do you have a
You know,
phone
the,
with me?
yeah,
That'd be great. Thank you.
I'll just do the thing. It'll probably make a really obnoxious
Actually, I can
noise.
do it. I'll do it because then I can see the time. Sorry.
Okay.
We need one of those like at the Capitol. We used to have them here
Like a
before
basketball
COVID.
shot clock.
A stop go card, but I don't think we ever had anything digital. We had a green light, green,
Yes,
red light.
yes, that's what we had. I've been coming for over a decade. So. Okay, and it's 2 minutes, you said. Okay.
Before you start, I just like to say it's nice to see you in person.
Thank you. Yeah, it's since before COVID, I think. Yeah. All right. Now, how do I start it? Okay. I'm concerned that the community is getting a feeling from this body that our community input is not valued and that it's a loss of your time, which I respect, to hear our input. The limit of 20 minutes per agenda item is really not well received in the community. And then also this new thing about signing up before 9 a.m. That was a real shock to me. Never experienced that before. I organized 2 small groups of disability advocates to meet at my home when Governor Polis ran for office the first time. And he made us many promises to include us, keep us at the table, and respect us. And that has failed. And I'm just so disappointed in our governor. I will be doing the same thing with Mr. Weiser. I've already set that up. And we do hope that there'll be a shift once he gets into office. It's really sad to see that the governor chose not to reappoint the most outspoken MSB member, where we really felt like someone listened to us and made these meetings accessible and inclusive for us. And we're just asking you as the remaining board to really not desert us. That's the feeling we have in the community right now. It's hard enough for us to survive as disabled people in this community right now with all the cuts, the service caps, the limits. We want to save the essential services. We also want to create rules that protect members appropriately. And we also want to keep our families from becoming unhoused. The disability community is not your enemy. We want to work with you. We can help, we can create good policy. We also have a lot of cost savings ideas. We are working with the Commission on Medicaid, and we're engaging with them. Unfortunately, they aren't even contracted with their contractor yet. I found that out yesterday. They haven't even signed the contract with their contractor. I mean, this is the kind of stuff that we in the community are just like, we hit our head in shock. So we're just asking you to please respect us, include us, and we want to work with you. We are not your enemies, but if you shut us down, it feels like that tension is there. So we're here to say, please work with us. Please don't shut us down. Please don't limit us in our comment. Thank you so much.
Thank you. Thanks for coming. Give your testimony.
This is Chris Sykes. We have Victoria Mao. Are you there, Victoria?
Yes, I'm here.
Great, we can hear you. Go ahead with your testimony, please.
Thank you for letting me speak today. I'm coming to you as the founder of Impacted Caregivers of Colorado. It was with great disappointment that we read that Laura was let go from her position as a chair. The disability community feels like the top organizations in Colorado have turned their back on us. There are a lot that are willing to come forward and support cuts, caps, changes, policy, etc., without a full foundation for those to be built on. Maureen just announcing about the contract not even being signed yet would be a great example. So Laura was a huge supporter for us, and we felt when we attended MSB meetings that we were heard. We did not feel when she was in attendance that the MSB members were just voting to vote on the side of HCPF and actually took the time to understand what we were saying or to ask questions that are vital to the community. And having her gone, we now feel in consensus that we no longer have an advocate on the board that will listen, that will ask important and difficult questions, that will hold HCPF accountable and make sure that members aren't just voting to vote. We are hoping that moving forward with Laura being gone, that someone else from the MSB will stand up and take her place as a very strong advocate for the disability community, will ensure that there is objectivity during voting and to ask the hard questions. Unfortunately, as Maureen said, because of the defeat that the disability community feels in those that say that they speak for us, it is feeling harder and harder to come forward and have any type of win. We definitely need those advocates in our corner. Thank you so much.
Thanks for your testimony. Mr. Sykes, do we have anyone else signed up for the open forum?
This is Chris Sykes. We do not have anybody else, but I will put out the call once. Oh, there we go. We have Megan Bowser.
Thank you. Sorry, I thought I had signed up, but technology is sometimes challenging. Thank you, board. Good morning again. My name is Megan Bowser. I am still the executive director for Family Voices Colorado. And I wanted to briefly acknowledge how disheartening it is to learn that Laura Carroll's appointment to the Medical Services Board will not be renewed. I recognize that board appointments are the governor's decision, and I do not know all the considerations involved. At the same time, Laura has been an important voice for people with disabilities and others who rely on Medicaid. She has consistently been willing to ask difficult questions, seek clarity, and push back when a proposal, sorry, my kiddo in the background, may have unintended consequences for Medicaid members. Those qualities should not be viewed as opposition to the department or the administration. They are essential and meaningful public oversight and good policymaking. A strong board should include members who bring different perspectives and are willing to respectfully challenge assumptions, particularly when decisions affect the health, independence, and daily lives of vulnerable Coloradans. I'm grateful for Laura's service and hope future appointments will continue to prioritize strong disability representation, lived experience, and willingness to speak honestly, even when doing so is uncomfortable. Thank you.
Thank you, Megan. Mr. Sykes, do we have anyone else signed up?
This is Chris Sykes. Just offering again, if anybody would like to provide open testimony, you can raise your hand, just like Kelly posted in the chat. Give it a few moments, Mr. Vice President. We'll see if any more hands go up. I do not have any emails.
You like to?
I was going to jump in.
Yeah, thanks, Adela.
This is Adela Flores Brennan for the department. Thank you to everyone who testified at the public comment. I recognize that it's been pretty disorienting this week and just in the last 24 hours with the changes. And I also recognize that Laura Carroll was very much an advocate. She was a consumer rep, a member rep, and outspoken in that way. And I also want to just make sure that we are acknowledging and thanking the board members who continue to serve. They are volunteers. They are putting in lots and lots of hours, and the efforts that we've been making to try and limit time have really been in the interest of trying to make sure that we can retain our board members since they are taking time off of work. And some of our meetings were getting really, really, really long. So, and I know that's hard. It's a hard balance because we want to be able to hear from people, and we also want to maintain quorum and respect the time of our volunteer board members. I also want to thank our board members for their inquisitiveness and their interrogation and their comments and your offering of, thoughtful changes. And so I do think that all of our board members continue to pay attention, continue to, even our newest one, who I know spent time last night reading through all the rules to catch up. I just want to make sure that we are recognizing the time and effort that you are putting into this, both here at the meetings and before coming. So I just want to make sure that doesn't go without saying. So I also wanted to carve out time because I forgot to do it at the beginning, to let Jarrett introduce himself and say, who is he and where is he coming from? So, thanks.
Thanks, Adela. Hi, everyone. This is Jarrett Hughes, new appointment to the board. I understand that there is some context and history here. And I think what I can kind of promise to this group is to come with a collaborative and critical and prepared perspective to this work. I think, my background is in demography and gerontology, and I have worked in Colorado's kind of public policy space over the last 10 years or so. Largely on kind of with that aging demographic lens, but obviously there's plenty of overlap with our disability community and have tried to be a good partner with them throughout that time period. Right now, currently, I am the president and CEO of Leverage Colorado, which is a new nonpartisan 501c3 policy advocacy organization. I have spent, prior to that, I'd spent the last 5 years in the governor's office. I had worked on kind of everything under the sun in that position, originally starting kind of in an aging specific position, but then kind of growing portfolio as I moved into different leadership positions. I've was on adjunct faculty at CMU for a while, teaching some introduction to gerontology and legal and policy issues in aging. And then prior to that, I was the project administrator for Colorado's Strategic Action Planning Group on Aging, which was created back in 2015 by the current Lieutenant Governor Diane Primavera. to really do a lot of that cross systems work as it relates to our shifting demographics. So I think that population trend analysis and kind of where our demographics are leading us is very much a perspective that I bring to this conversation. I think it's the lens that I view kind of all policy issues through. And I think, while I have spent time, I would say on like kind of the front end of the policymaking process, I think being on this side of things will be new. And so I'm trying to learn and absorb and kind of be a sponge in these scenarios. But I understand how challenging these decisions and this work can be, especially kind of in the overall kind of fiscal and budget climate that we are in. And I think that general discomfort, I think the challenges associated with decisions don't rule out the need to make them at times. But I think in order to do that, we have to do it in a collaborative and a partnership oriented way. So I think, again, that is something I can promise to bring to this table. So thank you, Adela.
Welcome to the board. One thing I say as vice chair is I'll certainly miss Laura Carroll, both as a board member and as being the chair. I think it is excellent, and I hope I can at least fill in for her at leading these meetings, although I can't in her advocacies, not having a family member who's receiving services like she did. So she will certainly be missed, and I just clarify that we can all reach out to her individually if you'd like to have some closure with her. Any other business before the board? With that, we'll stand adjourned.